So you've seen this slide before, thinking about what's been happening over the January to 2020 to May 2022 study period. We're seeing less red, more green. So that seems good, but can we dig a little more deeply to look at some of the implementation outcomes? I'll give you an example next. So we've published our methods in an analysis plan in Implementation Science Communication in 2022. There's a lot of details here that you might find useful in terms of how to define the different components of your implementation outcomes if you use the REAIM framework. For example, when we talk about reach, we are defining that as the absolute number, proportion, and representativeness of the sites and individuals who participate in the hypertension treatment in Nigeria program. There are 3 levels that we're measuring reach at: the program level, the center or facility level, and the individual level. We will use a combination of quantitative and qualitative measures to do this. And I've outlined the definitions on the right-hand panel for you to start to think about how you will define reach. The greater specificity that you have, the more likely it is that you will accurately measure it and report it, not only so that you'll understand what the true reach of your strategies were, but so that other people can also build upon and understand your own work. So I want you to take a minute and think about, for reach, for example, how that could be measured in your program across the program, maybe the center if it's relevant, and the individual. This slide walks through the details of calculating reach. This table shows for the program level the different outcomes, method of calculation, and data source. So for example, for the program level, we can calculate the number of participating PHCs over the total number of selected PHCs in the Federal Capital Territory. To do this, we simply divide the number of participating PHCs over the total number of PHCs in the Federal Capital Territory. And this is 60 divided by 243, so approximately 1 out of every 4 primary care facilities in the Federal Capital Territory are participating in the hypertension treatment in Nigeria program. Similarly, if we're looking at the number of participating PHCs over the total number that were reached out or invited, this would simply be the number of participating PHCs, 60 again, and the number that were invited. So 60 participated, so this was 100%. So we have reasonable reach across these 2 domains. It's a debate in terms of what is a high level reach. Over time, we'd obviously love to be able to integrate hypertensive services across 100% of PHCs in the Federal Capital Territory. That's going to take more research by our team and others. So here we're going to talk about the implementation outcome analysis for reach. These would both be on the program level, and I'm going to focus on the bottom one. That's the number of participating PHCs out of the total number of PHCs that were reached out in the Federal Capital Territory. So A is the number of participating PHCs, and B is the total number of selected PHCs in the FCT. So here, of the participating PHCs, we have 60 were approached, 60 participated, that's 100%. Now, overall, we reach only 24.7% of the total PHCs in the Federal Capital Territory of Nigeria. So that will require more research to learn how to scale up this implementation strategy approach to the rest of the Federal Capital Territory and beyond. So next, if we think about the center level, the outcome here is the diversity of participating PHCs and the staff in terms of size, ward, or local government area council, and baseline staffing levels. The method of calculation is that the PHC's size is equal to the number of patients and the number of visits. The diversity of PHCs is measured in terms of the ward, is equal to the number of PHCs in each area council. And lastly, the diversity of staff is defined by the number of staff in each area council at the baseline supervision visit. We use registry data and supervision data to report these outcomes. The table at the bottom shows the various PHCs by local government area council or ward. The middle column shows the number of patients within each ward, adding up to 100% at the bottom. And the number of visits is shown on the right-hand panel. So we see the variability in distribution across the various wards. Lastly, for reach, we'll talk about the individual level outcomes, which is the number of adult patients with blood pressure measured over the total number of adult patients within participating PHCs within the past 3 working days. We don't have access to all the patients all the time. So during these site supervision visits, our trained study staff look at the registers who've come into the clinics over the past 3 working days. To calculate this, we took the total number of adult patient visits to the health facility within the given dates. Of these adult patients, how many had their blood pressures checked during their visit? And of the patients who had their blood pressure checked, how many had high blood pressure, and we reported the median in this. So the panel on the bottom shows the outcomes that I've listed above across the overall wards and for the overall study. So we can see variability in the total number of adult patient visits to the health facility, with a low of 1,088 from Coogee to a high of 4,371 in Abuja Municipal Area Council. So a 3.5, almost 4-fold difference across these 2 LGAs. Of the adult participants, all of the individuals had their blood pressure checked during their visit. So this became a matter of routine practice. And of the patients who had their blood pressures checked, how many had high blood pressure? And this was a remarkably large proportion of individuals. Overall is 88%. So this represents care-seeking behavior. Individuals with high blood pressure are more likely to seek care than individuals who do not have high blood pressure. So I'd like to show a few photos of our team in action. This is Dr. Oji on the left, participating in the National Hypertension Protocol Development meetings. Next, we have one of our team members who's collecting a dried blood spot sample. And we collected this because we did sub-studies to understand the seroprevalence of IgG antibodies among frontline healthcare workers in the Federal Capital Territory during the COVID-19 pandemic. We're grateful for Regina for leading the way on this. And last, we have Grace, Eugenia, and Tunde, who are participating in qualitative research training, so embedding capacity building into our implementation research efforts. This work's also been coordinated by Drs. Lisa Hirschhorn and Abigail Baldridge.